Our guest is here in the studio, though. Dr. Ouma Oluga is the Principal Secretary for Medical Services in the Ministry of Health, and he was there in Washington when the deal was being signed. Yeah,
I was there throughout when the deal was being negotiated.
Even through the negotiation of the deal. Karibu sana, Daktari. And it's good to have you here. First, of course, we start with the day's quote. You know the drill. Janet will give you the quote.
The quote today is by Kofi Annan. Back in 2004, he said, "If corruption is a disease, transparency is a central part of the cure."
Very true. Yeah, and corruption is actually a disease.
It is.
Yeah.
Yeah.
Corruption is not. It's not something that happens. It's a rot that is within you, and you have to be somehow dark-hearted to say that this thing that is meant for everyone, I'm gonna mess it up by making it just mine. So it's for sure a disease.
It's a big ailment.
You have to be perverted in some way too.
Yeah. That's honest.
So now, Daktari, we have the US-Kenya Health Cooperation Framework that was signed last week, and you were there.
Yes.
Can we see it?
Yeah.
Yeah, so we have already promised that we will make it public. But making it public means that we have to follow the processes. So first I have to take you through the processes of getting the deal. Then now you understand the processes of making it public. So the processes of making the deal, so first and foremost, Kenya has had a very long relationship with the United States. So there's nothing new. That's the first thing. So if everyone's antenna is up, they should know that the antennas should be down. We've related with the United States in many areas, not just health, for 50 plus years. Secondly is that all our relationships or partnerships have been governed by something we call DCFA. DCFA is Development Cooperation Framework Agreement. Now, traditionally, DCFA has been signed by the National Treasury, and it always covers 5 years. The last DCFA was signed in 2021 and has not yet come to an end. But there has been a shift in what we call foreign policy in the United States government, and you saw that shift come with the stop work order in January. So when the stop work order came, a number of things that were in the DCFA could no longer be implemented as they were. So that's the genesis of all of this. Now, from a health perspective, the DCFA covers all areas: agriculture, health, all those kind of other issues, and from a health perspective, that was very hard-hitting. I was not the principal secretary then, but I was in the Ministry of Health, and I was the director in charge of international health relations at that time. And I was the one tasked by the then cabinet secretary to look at the impact of the stop work order. And we did our work. We came down to 3 areas that were significantly affected. One was the health workforce. The second was the issue around commodities. And the third was the issue around data systems. There were many things that were affected, including the economies, people losing jobs. But from a health perspective, we narrowed down to those 3. Now, having narrowed down to those 3, we started engaging with the United States government. Then, because I remember the first week, and I'll give this story. The first week of the stop work order, we had some very significant issues in the country. There is a medicine called nevirapine, the liquid nevirapine. It's given to babies whose mothers are HIV positive. We had adequate numbers of nevirapine in the country, but they were in a mission for essential drug supply, MEDS. Now, MEDS is not a government institution. MEDS is contracted by the United States government. So you want nevirapine to reach the hospital so that babies can get it, they have it in stock, but they're telling you, sorry, my contract has been cancelled, and I have no relationship with you. The same happened with Tesunet. Tesunet is a IV, is a medicine that is injected to treat malaria. Just in context, we have 12,000 malaria deaths in the country. So they're telling you, it was in another organization called IMS, Imperial Management Services, again contracted by the United States. So telling you, I have this medicine, but sorry, I can't take it to the hospital. It was a very frustrating moment. I was dealing with all of that then. So we started writing diplomatic engagements to the United States. Like, okay, first we just talked about emergency access to some of the things that were already here. And so that's the time this thing began. And so we did that for 3 months. After 1 week, they gave us this access. But then we started thinking, how do we do things differently that we never get into such a situation again? So that this is really how we have engaged. And so on the issues around data systems, we decided to aggregate and to collect. Previously the mechanisms used to be that the USAID would engage with an entity. That entity would then go to support the hospital. So the computer, the software, is not in the hands of government. So when CS Dwale and myself were appointed in April, one of the first things we did in May is to take over some of those systems and to say that they have to be put under what we call the Digital Health Agency, the DHA, which is a government institution, so that then we first and foremost are in charge and protect our data.
Wait, hold on. So USAID had all these systems in place.
Yes, I want to make this foundation so that people understand.
But government did not have...
No, they did. Yeah.
They did what?
Yeah.
Did government have access and control to the information that was being held by USAID?
There was something called implementing partners. I hope you understand. So implementing partners means that I choose you to do. So the government has allowed me to, under this DCFA, the Development Cooperation Framework Agreement, the government has said, yes, I think this is something that is important. It's something that is strategic for Kenya. But the way in which you're doing it, you go and choose somebody to do that work. It's not the government.
As they implement on the ground.
As they implement on the ground.
Okay.
So the government didn't have access.
So there was aggregate access through reporting mechanisms, but in terms of at that level, it is at the hospital. You get.
Yep.
So no granular data.
No granular data. But you see, now until we have now granular data under the digitization of health, and I wanted to come to that a bit later. Remember now, it is under this government administration that now we are talking about digitization as a key priority. And now I think it's very important that people understand what that means. And having that national data as a strategic asset, but first and foremost owned, managed, secured by the government.
Okay, foundation laid. So now the process of making this deal public.
Yeah.
My foundation, I'm still not on that. I want to completely understand what you said. Stop work order comes. You realize that some of these USAID funded programs, government needed control of the information that they had. Which means that the government did not have control of information that was being
That's why they're called
held.
That's why they're called vertical systems. You've heard this word, vertical. Vertical means that they are parallel to the government system.
So in a facility that was being run somewhere, USAID funded with an implementing partner called, Latif Community NGO.
Yeah.
I was running a facility supporting patients who would come to the facility. Who was in charge of this data?
So there was a Kenya EMR. So this Kenya EMR was a system that was put in some 2,200 facilities.
Okay.
What does EMR stand for?
Electronic medical record. So the Kenya EMR was put in these facilities. It's been working. It was doing what is called reporting but the actual data was on the ground, in the facility.
In the facility itself.
In the computer, and this is very important, in the computer and a system that is not Kenya government owned.
Okay.
That foundation is important because we want to know where we have come from and why now we have to do the things we are doing.
That's why I was asking that.
Okay.
So that I say that this particular facility being run by Eric Latif NGO, community NGO, has been supported by USAID funds to establish and to operate. So many staff are being paid through this USAID funding. The equipment that I have here has been bought with the support of the USAID funding. So I have the computer here. I report, yes, periodically as I'm required to, but I'm holding the data here that says the patient that comes here is called David Ojwang, say, right? So I am the one with the information about David Ojwang's medical history. And you're saying that the EMR was just me, I report and say, I have a patient, 42-year-old male who comes, that so on and so forth. But I'm the one who knows it's David. And because this computer is owned by USAID, it means that USAID is the one that has the information that David Ojwang, 42-year-old, has been coming here.
And then that's what we consolidated in May to now have all of that under the government.
You had asked about how it's going to be made, because we want to come to, I know you're saying it's so important that now we have it under the government, which is already bringing a bit of contention, which is why you're here. So we'll come to how.
I hope that that foundation alone has...
but you were asking how to make it public so that we go in. We recognize that we don't have you for too much time. So let's go into how and when it will be made public. I think that was Mariam's question.
So then, of course, the USAID was closed in July 1st, and then now we went on to now starting a formal engagement, which actually began in August. So we had several meetings looking at what is it that is important for Kenya, what is it that is important for the United States government. And again, for context, I wanted to say that the US government has remained the largest bilateral partner to Kenya for years. The last time I was in this show, I mentioned to you guys how the financing of the Kenya health system goes. And I mentioned that around 82 billion comes from development organizations, otherwise called donors. Now, out of that, the US government remains the largest of all those development organizations. And so we come from a place where our healthcare system has been supported heavily by the US government. So anyway, we go into engagement. So the way we do the engagement is that, first of all, there was a scoping exercise. We agree on the areas. We start to develop the template. The US government did what they call the America First Global Health Strategy in September. And that was heavily informed, by the way, by Kenya. So it's not a coincidence that Kenya is the first country. When we were doing the engagements that they were doing their policy on how are they going to do foreign policy around health, Kenya became a country in terms of how do we do this. And so if you look at the America First Global Health Strategy and our priorities, you will see there's a lot of similarity because we sort of did it together. Fast forward, we start the negotiations. We negotiate now. In the negotiations, so you need several institutions that are key. Ideally, this is a foreign affairs matter. And I have to be extremely grateful to my counterpart, colleague, PS Koresingwei, because he said, this is fine, I'll give you all the support because the discussions are very technical. You lead this.
Sorry, PS. Sorry to interrupt, PS. Just because of time, again, we're very cognizant that we don't have very long, too much time with you. Let's keep the answers as brief as possible so that we can make it through as many as possible.
Foreign Affairs, Attorney General, National Treasury. So you have to go through that chain before you get anything approved and signed. And so once we sign the documents, the things that will make it public, one is that we will again, so from MFA, it has to now come to us. You know, that's why you saw it signed by His Excellency Musalia Mudavadi. So then it has to come to us. After it has come to us, it will go through the Attorney General, and then after that, we will now have it discussed by Parliament, and then not Parliament as a whole, just the committee, and then we will make it public. Yeah.
Is that not the cart before the horse?
Where?
Should it not be, like our Attorney General has already looked at the
Yeah, the Attorney General has to approve it, but it has to be, now that was before signing. Now it's an agreement.
Oh,
now you have to institute it within government.
Okay. The return to the AG is the institutionalization,
institutionalization
of domestication of it.
Yeah, the domestication, so that now it is deposited as one of the Kenyan government agreements.
And Parliament, was Parliament involved in
this is actually an executive function. So Parliament, it's not a treaty that Parliament sort of have to approve. And I think chairman of the committee, Dr. Nyikala, has made that public, that this is not a function of Parliament. But the reason why we require it to go through that committee is because it has budgetary implications that then they have to look at in terms of the budget making process.
It's America first. Our interests are secondary in all this.
It's America first, it's Kenya first. Yeah.
Okay.
Interest is not secondary.
Does the deal say America first? It says
the deal does not say America first. So the deal says health cooperation framework. So initially it was meant to be an MOU. But, an MOU doesn't generally work for Kenya. So we went through that motion. By the way, that alone we negotiated for over a month just to have it as a cooperation framework. And this is where our foreign affairs and the lawyers came in handy, because then we are looking at what instruments work for the country. So if you look at what America has done with other countries, they have signed MOUs, not cooperation framework.
Okay. I want to get into the how much, into the how, but let's start with the biggest concern, which is the privacy issue. What Kenyan health data will be shared with the US government, and to what end?
So, I know. So first, the cooperation framework. And then the cooperation framework leads to 3 documents. One is the implementing framework or the agreement. So how you will now implement it. Number 2 is the financing agreement, or how all this money will be embedded within the national financing architecture. And number 3 is the data sharing. And the data sharing, I know, is what is of a lot of interest to everyone. And that's why I was laying that context before. So first and foremost, Kenya has invested in a very heavy digital health infrastructure. We know we have the Digital Health Agency. We have the Comprehensive Integrated Health Information System. So in summary, this is just a pipeline, and then all hospitals plug into this pipeline. And then at the top is the registries. So the registries are where the data is pulled from. So you have the data, let's say, of patients, the data of health workers, the data of hospitals. So you have all those registries at the top, and then you have this pipeline, we call it the Health Information Exchange, and then you have the downstream, which is where the service delivery happens, where the hospitals plug in the hospital management information systems. So now we have consolidated this as a country, and I think Kenya is one of the only countries in the world that have done this, to sort of have a robust data architecture. Now, that alone meant that this information is in the hands of government. And so for you to access it, you have to sort of agree with government. Yeah. But in terms of the implementation of this framework, it is important that you report. You cannot tell me, for example, that I'm giving you money to, say, give ARVs to, let's say, 1.3 million people. But you have to show me that there is 1.3 million people. You understand what I'm saying? It's just right that way. Yeah. And so we have to then look at what mechanisms do I go through to show you that. Okay. And so what we did first is, and I think also the data commissioner has been public on this, on your own platforms, the Nation Media Group here, saying that the Ministry of Health consulted the data commissioner on that. And number two is that we have the Digital Health Act that says who is the data controller, who is the one that can access. So what we did is that first we embedded that all this data will be owned and governed by the Kenyan agreement, but by the Kenyan laws. And number two, accessing them will require 4 things.
Before you give us the 4 things, hold that thought. Don't lose them. We'll come back. We have to go into a break. So you'll come back and tell us the 4 things that are required as we continue to just ask questions about data, because that's a big concern to many. Dr. Ouma Oluga, Principal Secretary, Medical Services, is our guest right now. It's coming up to 7:30. We'll come back after the break and continue the conversation.
$1 billion. Thank you so much, Kikombe, for sending us that WhatsApp Nation video. Our PS agrees with us that we should not get desensitized.
We shouldn't get desensitized. And we have just negotiated 208 billion for Kenya.
Right. Tunarudi hapo too.
So you can calculate how many years that would take you.
To spend to get to
at 50K, even if you tripled it to 150 every Friday.
Every Friday. It will still take you quite a while. But thank you so much to the Kikombe for sending us that WhatsApp Nation video. We truly appreciate it. And your billion series that you've been doing this whole year has been amazing. You're a great fixer. Send your WhatsApp Nation video. Now I'm talking to you, Wewe. Yes. Send your WhatsApp Nation video to 0112 500 400, 0112 500 400. Could, for example, say, my name is Dr. Ouma Oluga, and my bit in fixing the nation is ensuring that Kenyans have an understanding of the Kenya-US health deal. That's my bit in fixing the nation.
That Kenyans are healthy.
That Kenyans are healthy as well. Yes. A happy, healthy nation.
Sawa. Convince us in an hour. Felix Mushemi, you're asking how can you send a message? Mariam has just given the number, 0112 500 400, because maybe people want to WhatsApp and ask questions. So please, you can call as well. Yep. 07, I'm turning to you, Mariam.
038 858. Yes.
0719.
In the next hour, then.
In the next hour, very quickly, John Kinua online is saying this data can be used to develop pharmaceuticals and medical devices. Will Kenya really benefit financially from this? We'll see. And then a lot of people are saying, sort UHC first. So 2 people have just talked to 3 people, actually.
UHC staff.
Omari, Hamad.
And I was here last, you asked me that, and we went and paid them their salaries.
Okay.
On a permanent and pensionable basis. Their contracts are held by the counties, but the ministry has done its bit, the president has done its bit. They are earning like they never earned before. Some of them double their salaries.
But without contracts yet.
No. So they had, the old contracts have been signed by the county governments, and you have had the president urging the county governments to because now you can imagine I've already paid you, so it's just about changing how it is written.
We'll see if we can ask you that much later, but you were talking about
I've already answered
four mechanisms. You've answered.
No, there's a question here on the framework, on the cooperation agreement framework on staffing. So we'll get into that.
Yes.
Later.
We'll get into that.
So, John, have you mentioned about sharing of pathogen specimen?
No, I haven't.
So Sebi Musundi is asking, please clarify on the sharing of pathogen specimen and sequencing data, and how does that benefit us?
So there are so many things that are misunderstood. So first of all, am I allowed to say some things? I am internationally trained negotiator, and I was privileged to have this position and to be the one leading the Kenyan teams. I've done a lot of negotiations, including the code of practice for WHO. Of course, in country here, people know the documents I've signed. And so I am not such a lightweight on the table. But I wanted to say that so that Kenyans have trust in their professionals, because it's important. If you don't have trust in your professionals, as a country, just the same way you should have trust and patriotism and pride in your athletes, then as a country you don't grow. If you don't have some innate feeling that, okay, Dr. Luga is there, I have seen this, these are people that I know their face, I know they're people of integrity, I know they mean well for this country, then you will never ever sort out the trust deficit in this country. Now, having said that, I have to mention that we did not negotiate a specimen sharing agreement. And we agreed with our American counterparts. Yes, this is something that they really wanted, but we said, wait a minute, no, we will not do it. Okay, so that's the first and foremost thing I wanted this country to understand, that you have professionals in this country who are competent. I had a team of 93 people who are extremely accomplished professionals in this country who know. And, you know, negotiations is about two things. One is what do you want? Now, what do you want is given to us by our president. So he sets the agenda through the cabinet secretary guiding us. But how we get it is our mechanism as the people negotiating.
All right.
Okay.
So it's not in the agreement that there will be a specimen sharing. Of any sort.
So what we have already now, we have Walter Reed in Kericho. We have CDC in Kisumu. We have CDC in Kilifi. So what we agreed, so that they continue to operate, otherwise they would close, is that we will continue to test specimens together, because they're already here and we're already working together.
These are American research institutions.
These are so it's a partnership between Kenya and
the US.
You have KEMRI here. You have KEMRI with CDC. You have Kilifi, KEMRI with CDC. Yep. You have Walter Reed, is also American organization with CDC. If we say that we are not going to test pathogens together, then it means that tomorrow they close shop. So we said we are not sharing any specimens with you. What we will do is that we will continue to test pathogens together. And I'll tell you three things. One is that today, if you wanted to test for some things, like up to recently, until we did the lab here in KEMRI, you could not test polio in country. Okay?
Kenya did not have capacity to test polio.
Not Kenya, Africa. So you had to send it to Brazil or to Indonesia or to the Americans. Now, our partnerships is important for our healthcare system. I hope you understand. If we wanted to do, for example, a vaccine test, so we have a vaccine that we have to now do a test on that vaccine to make sure that it's efficacious. Apart from South Africa, there is no other capacity in the entire Africa. So we leverage on that because the US already has that capacity. So we work together to test that. And it is for the benefit of Kenya, because you have to register vaccines, you have to give children vaccines. But I have to test whether this vaccine is safe for you or not. We rely, for example, on the Food and Drug Administration, FDA, approvals of medicines. We rely on also certification of Europe and WHO. So our Pharmacy and Poisons Board leverages on these things. So we have to understand that His Excellency the President wants to make us a first world, right? But we are not first world now. So again, Kenyans, as you listen to me, understand the context where we are.
Quick follow-up. So we won't be sharing specimens with them, right? But we will be testing together, as you said, at Walter Reed, at the CDC. So essentially, they will have access to data from the testing
when we do testing of specimens, we blind them.
Okay.
Blind.
What does that mean?
What we mean by blinding is that when we take a sample, for example, there is a strange disease that has come in our borders. We think, hey, there's something here. So let's say it's at Kenyatta National Hospital, Mbagathi. The sample flows to our reference laboratories. We have all reference laboratories at the national level. Now, at the reference laboratory, when it goes to the reference laboratory, it is no longer, by the time it leaves hospital, it's no longer Oluga.
It doesn't have
it doesn't have an identity. It is a sample.
Okay.
So it is so you describe the sample. So this is a sample of lung tissue of a patient who presented this way.
Without specifics.
There is zero specifics. So by the time it gets to, first of all, our national reference, forget about by the time we start testing together. By the time it leaves our national reference to now the testing places, now it doesn't even have that description of the patient.
So
it just has what needs to be done.
I wasn't even actually talking about the patients. I was asking about data on the actual pathogens and specimens. So yes, it will say lung tissue, but they will have access to essentially, this is lung tissue with this strange disease, in Kenya. Yes, so that data they will have access to because we're testing together. They can see that. It doesn't say, lung tissue from person X, but it does say
it's the same as It's the same as right now.
Kenya.
It's the same as right now we do something we call, let's say, cancer markers. So cancer markers right now, even if you go to, and I'll mention this, I think sometimes we sensationalize things. If you go to Lancet, let's say a private laboratory, and they have to test some cancer markers, which we don't do in country, they send those samples. So when they send them,
outside of the country.
Outside of the country, they de-identify them. But it still goes that this is a breast tissue. We want you to test for us the cancer marker so that we know what it is. I hope you understand.
Okay.
So this happens. This is routine all over the world.
But just wanted to know.
So even that way, South Africa will know that, okay, there is a breast tissue that has come, that information is not useful. And the way in which there's something we call international health regulations, IHR. So international health regulations governs how you use health information. So it's already at that level. So whether they know that, there's a lung tissue with this disease in Kenya, and it's at the lab level, that information belongs to Kenya. It doesn't belong to the US government.
Okay. I think it's
it's at that laboratory where both of our people are working.
There's something about now aggregation of data, which we'll get into, because I think, yes, one tissue, one specimen might not be the most useful of information, but how data works is now it's aggregated.
That's what I was going to come to.
So, but before that, we were talking on, you said that, all the data will be owned by GOK.
Yes.
And those 4 things you were to talk about.
So in terms of, first of all, this data sharing, and it is sharing. So that means it's both ways,
Are they sharing their medical records with us?
Not their medical records.
Not records,
it's aggregated. It's aggregated data.
Yes, they're aggregated medical data.
And I'll talk about what aggregated data means. So this data sharing, number one, there has to be a request in terms of what information do you need. Okay. Then number two, there has to be a mechanism of how I give it to you. Now, in our mechanisms, we have put. One is that we have to have an approval both by the Digital Health Agency and also by the data controller before we provide it. Number 3 is that you have only to use it for what you have requested, and then you have to feed back for us. So we have put those access safeguards within that provision. So for every data that is provided, there has to be a request.
Okay.
You understand? So that already people will know, this is what has been requested.
Okay.
Yeah.
And then you say how it's given.
And then how it's given, how it is used. Yeah. And then you have to give us feedback on what you
that's the fourth one. That's the fourth mechanism.
What you did with it. Yeah.
Okay.
Yeah.
I don't know if we've exhausted data. So, it just seems like...
so I'm just trying to understand fully.
Yeah.
So, for the avoidance of doubt, this is not to say that the US government will have access, for example, to SHA records.
No.
Or anything under the Digital Health Authority.
We have a very, and that's the foundation I was laying when I came here. That has been closed. Right now, it's only the Kenyan government that runs the comprehensive integrated health information system. We took over all those systems. There were several systems. There was a system for TB. It's called tibu.go.ke. There was a system for vaccines. It was called chanjo.go.ke. There was a system for now the malaria. There was a system for, we used it mostly for CCCs and HIV, the one that we were calling Kenya EMR. Now we're even expanding it beyond that. There was a system for blood called DAMU, okay? All of those, we have put them together, and we have now taken them from hands of
third parties.
Third parties, thank you for that word. I was struggling there a bit, to government.
Right.
And so right now, we can confirm to the entire country and each citizen that your data is in the hands of the government.
Alone.
Alone.
You know,
and that is why, by the way, can I be honest with you? In a previous arrangement, can I be a bit honest? In a previous arrangement, the US wouldn't need to sign a data sharing agreement. Why? The answer is with you.
Before we move,
I'll hazard an answer.
Wait, you said something, and I don't know whether you answered it already, but you mentioned that they asked for a specimen, but you said wait. You said that we are not going to share it yet. Before we went into breaking down...
We didn't do a specimen sharing agreement.
You didn't do, but they requested.
It's part of the request.
It's part of the request.
So it's part of why I wanted Kenyans to understand that they have professionals who are competent enough to negotiate.
What would be the conditions within which you would now say we're going to share? Because you said they requested it, but you said we haven't shared yet.
So the conditions for pathogen sharing, so this is a big discussion internationally, and there is even something that is going on right now called the pathogen access rules, basically. So the conditions, generally Africa has the same position, all African countries, and in Geneva, all African countries took the same position that there has to be what is called benefits for countermeasures. Countermeasures are things like when you've taken the pathogen and you've used it, for example, to develop a vaccine or to develop a treatment, we want to be part of that. We want to be part of the patents. That's the only useful thing around pathogens, by the way. There's nothing else that is useful around pathogens, just so that people know. The only useful thing is that if you developed an Ebola vaccine, that you're like, okay, this Ebola vaccine, you developed it using specimen that was from my country. Let's have a way in which we can benefit together. Yes, we know that it takes a lot of investment, a lot of research for you to also develop those vaccines, because I do not have the capacity to do it. Otherwise, I would not be. You would not.
The least you can do is give me a discount on the vaccine.
Yeah.
Okay.
Thank you for saying it. So those are the benefits that are now being negotiated. Yeah.
So, still on the data question, there's an obvious, what would I call it, concern around, even if it is aggregated health data, and it is given under the conditions, which is, there's a request made for the data, it's approved by the Digital Health Authority as well as the OD, the Office of the Data Protection Commissioner. We could give that aggregated health data. And there are worries around, one, the weaponization of it. Like, it is still our data, our health data, in the hands of another government.
No, it is for the data that is provided, and I wanted to I don't know whether I should read. It is.
Please read.
It's specifically for the implementation of this cooperation framework. So anything that is outside of this cooperation framework, you don't have authority to ask me for that data. So, for example, we have 6 areas in the cooperation framework, and let me go through that. So we have surveillance and disease outbreaks, and that is where we have the TBs, the HIVs, and all these outbreaks. We have the issues around the health workforce that we are supporting at service delivery. We have the data systems, we have maternal and child health. So areas where you are supporting me, because I cannot tell you that you gave me this amount of money. I built 10 child health centers, and then I'm not giving you information whether it was it was done or not. I think so, and it's aggregated, and even that aggregated is from so it's aggregated data from aggregated systems. So what aggregated systems means that it is not from that health facility that I built. So that health facility has a system that goes into this platform, the HIE, Health Information Exchange. Then it is aggregated. Like out of 10 health facilities that I built using your funds, I saw 20 children. These 20 children, this is the I prevented this number of diseases, I immunized this percentage, and it's aggregated data from aggregated systems. And let me put this a bit, and I know it's also another thing that is being discussed. So we already do this, by the way. We do it through IHR. We already give our data all the time to WHO. Now, and I have to mention this so that people don't feel a bit. So the US government, they are doing their own mechanism in terms of foreign diplomacy and things like that. And part of that is that they, in their own way, want to sort of disengage from WHO. And so I think they're just trying to also figure out, how do we get this information? It's already part of the international health regulations to give aggregated data. So we give, for example, WHO. So when we talk about doctor-patient ratio, we say WHO, doctor-patient. How do you think WHO got that information? How did they calculate it? So Kenya gave them that information. So now, because the US is not going to be part of that mechanism, they want their mechanism. And it is okay. And by the way, it is not just the richer countries. For example, I'll give you a good example of, for example, Cuba. Cuba for a long time was not part of that WHO mechanism. You get? But Kenya still had an agreement with Cuba. So I just wanted to allay fears that there is nothing that is strange out of all of this. And Cuba is not like a superpower that you can say, oh, you know, they will access our... So I wanted to make sure that we are on this,
fears. We'll see if they've been allayed. You wanted to get into something else?
I wanted to ask a question. So in terms of this cooperation agreement, is this categorized as aid? Is Kenya seeing this as aid or as a just partnership?
It's partnership. For us, how we see it is partnership.
So when
number one,
partnership, what does that mean to the American? What's in it for them?
Isn't aid part of this whole framework?
So what's in
it for them?
What is in America?
Aid, you can say.
Can I be
aid?
So
let me just explain this. What I mean by this question, Dr. Harry. Aid, in how many of us visualize it, aid is some sort of philanthropy. I'm not doing this for anything in return. I'm doing this to help you because I see that you've got need and I give you, right? If it's not aid, then
can I be honest?
There's no free lunch.
You know, if there's TB in some part of the world, there's no part of the world that is safe. And so it's not necessarily aid. It's about all of us protecting the health of the world. And to be specific, protecting, let's say, our own health. Because if you have disease outbreaks anywhere, it's a problem to even the greater economies. And that is why, by the way, it is a concern, even for Kenya, if there is a disease outbreak anywhere. Like right now, we had an issue with Marburg that was Ethiopian government announced Marburg. It is a concern for the Kenyan government. So that is the premise upon which all of this cooperation is made. And that is why number one there is surveillance and disease outbreaks, because I want to protect my populations, the health of all of those. But more importantly also, Kenya is a strategic partner to the United States in many ways. So it is in the best interest of the US that Kenya is also a strong country. Now, why we look at this as a partnership is because it's not that I'm giving you money. It's about we are putting money together. By the way, there is co-financing that is embedded in the framework. Co-financing means that I am putting this money when you put this money.
We'll talk about that. We get that.
And then that's...
So this is not aid. It's
a partnership. It's an agreement between...
And the main reason that America is putting 250 billion shillings.
It's 208 they're putting, then the other one is ours. The 50 is ours.
So 208 billion shillings.
Yeah, but they are conditional.
They support Kenya and
they are conditional. We put ours, then they put theirs.
And it's because they want Kenya to be a strong country.
Yes.
Not alone, we shall not pay them, but they shall not ask for it.
It's so that
you see, they're not asking for anything in return, basically.
No. They're not asking for anything in return. You will read the agreement in yourself. Yeah.
Okay. It's 3 minutes to 8. The PS is staying here with us for the next hour. We have a couple more questions. That if you've got a question, you can send a question on WhatsApp. What's the number?
0112 500 400. 0112 500 400.
Okay. And in the next hour, at some point, you shall open the phone lines and we shall tell you what number to call. So you can call in and maybe you can ask a question or two to the Principal Secretary for Medical Services, Dr. Ouma Oluga. It's coming up to 8 a.m. Good morning.
Through and implement.
Yeah.
Yes, we continue our conversation with Dr. Ouma Oluga, Principal Secretary, Medical Services, talking about the Kenya-US Health Agreement and MOU. I wanted to dive into the contracts. You had asked, or you before the break, Eric was like, so it means nothing is required of us. This thing is free. It's it's a partnership. The US want nothing in return. Sawa.
It's you people saying that.
You literally he asked that and you answered and said,
No, I mean, they don't want their money back. Let's start with that.
Okay,
at least
204 billion
but
shillings.
Of course, Kenya is a strategic country for the United States. It's important for them, I think, for the protection of both of the citizens of Kenya and the US. I mean, when you prevent and you tackle TB in Kenya, you definitely are also tackling TB in the US because we are we are a global village. But more importantly, of course, the US is still a global powerhouse. They certainly have their interests. As I've mentioned to you, they are now rethinking of their engagements with some of the global health initiatives, the institutions such as WHO, and so they are thinking, can we do this on our own?
Okay.
So maybe they are establishing another mechanism of this, them having the same informations of increasing their footprints in many countries. I think there are many American companies.
Okay.
The pharmaceutical and the health industry in America is one of the most robust in the entire world, I think.
As the MOU matures, we'll have
the agreement.
My bad.
And by
as the
by
agreement
the way,
matures, we will be able
let
to...
me take advantage of that and say that everything that was circulating online is documents that are strange. And I have to say that, of course, as you say, there's a bit of apprehension, there's a bit of anxiety, and so everyone is trying to do something. And I really have to commend my team that you have to have 93 people, and the documents that are circulating are completely alien to what we are discussing. I think you Kenyans have good professionals.
So what we have circulating is none of this.
None of this.
I want to ask again.
Including the data issues that was done. I heard there was a lawyer who had done an advisory on some. So the document he used was very strange to what we were discussing.
You know, you had given us the process for how, when it's going to get published and what it has to go through. I'm just wondering, given that it is already signed,
what does it change?
Yeah,
right?
what does it change if we share it now?
No. It's just about the institutionalization of the agreement and then it's shared. That's it.
How long should that take?
Yeah.
It was signed by Foreign Affairs.
It was signed last week.
Cabinet Secretary.
It was signed last week. Come on,
so,
it was signed last week. We have just come back. We have just come back.
For example,
I have not even recovered from my jet lag.
It's okay.
I have not gone to the office.
Okay.
I have not written a letter.
This is a service to Kenyans.
Jet lag.
I know, besides jet lag.
That's all good.
Think about a draft law going through the various stages of parliament. This is not a law, obviously.
No, it's not a law. It's no, there's not.
I said think about, and the fact that we have access to it as it goes through all of those. This was an executive function. Yes, it's not a law, but it has already been signed. It's being institutionalized. I don't think anything is going to change between now.
No, it won't.
And so then again, what harm does it do to just publish it?
I think the reason why institutionalization is important is so that it gets through the pathways of implementation, and then now because it doesn't harm, as you say, but also why should we discuss something that we've not?
We might circle back to some of these pain points. I just want to get in a little bit into the context.
I hope there's no
pain points in terms of Kenyans wanting to better understand it.
Okay.
The contractors, what will their role be?
Which contractors?
In the agreement? Doesn't it mention specific U.S. companies? Maybe they're not contractors, that's the wrong word. Zipline and Ginkgo Bioworks. American-based contractors, they've been assigned roles under the MOU. Yes or no?
Which agreement is that you're Can you read it for me? I have mine here.
Okay. How about
You should share yours with us.
reframe it.
This is why
Let's ask you
This is
this.
already okay. So let Latu
We are all
reframe it.
reading.
Let's
We're all
Previously,
reading from
Dr.
different-
Yes.
Previously, Dr. What we had in the previous framework
Yes.
was implementation through implementation partners.
Yes.
Right?
Yeah.
Who would then be contracted. So USAID would, contract a small NGO and say, you're implementing in this
Yeah.
community, and so on and so forth. This one is government to government.
Yes.
Are there any third parties that are going to come in
Not
during the implementation of this, either at pharmaceutical level, where you're saying that they are preferred pharmaceutical companies, they are preferred research institutions?
No.
Is there any?
So, our cooperation framework anchors government institutions. So, if anything is going to be done around commodities, it's going to be KEMSA. If anything is going to be done about surveillance, it's going to be National Public Health Institute. If anything is going to be done about how to pay for services, it's going to be the Social Health Authority. If anything is going to be done around data, it's the Digital Health Agency. If anything is going to be done about quality, it's our National Quality Control Laboratory, and it is in the document. And there is no mention of private or third parties in this cooperation framework.
Okay.
Zero.
Okay.
But I have to say this. I have to say that now, KEMSA doesn't manufacture its own medicines, does it?
No, it
But
doesn't.
there is also no strings attached on, and by the way, let me mention, and when the reason why we really pushed for the G2G is because of, one, the experience I gave you earlier of what we went through. Like sometimes, what happens if you have nevirapine in the country, but it is not in the hands of government, but children require it? What happens when you have a Tesunet? It is in the country, but it is in a private party that is contracted, and it is not in the hands of government. So we pushed back, and by the way, up to, I can say 3-4 days before, that was still a very contentious issue. I remember spending the last 6 hours with the very top, just trying to frame how the G2G will look like. Because it's something that is also, can I say, new to them? As I mentioned to you, the other mechanisms were more through implementing organizations. So they're also looking at how does this look like? And they are relying on the experience and expertise of Kenya to also show, and that is why the Secretary of State, Marco Rubio, said that we are looking towards Kenya, even teaching other countries. He mentioned that because there are also some things we are bringing on the table that are like, wait a minute, that sounds good. How does it work? And then we agree on how it works. Okay. And so there is no third party. There is no strings attached. One of the things that actually sold it, and I have to mention it here because when we give example, the Global Fund, for example, uses KEMSA in Kenya. The Global Fund saves 16% by using KEMSA. When they go to other countries, Uganda, all of where the Global Fund is also there, their costs are 22% higher. If you look at mechanisms for supply chain, for example, KEMSA saves up to 32%. With all the problems you Kenyans think KEMSA has, it's still one of the strongest, most digitized, most efficient drug supply organizations in the entire world.
True.
And it has been assessed. Can I just finish that? When the US government did something that we call assessment, they scored KEMSA at 92%. 92% made KEMSA the 5th most efficient DSO in the entire world. So we are in a good space as a country to use our institutions. And that is what we have been championing as a government, that the government is in a position to do all of these things, and the government can be held accountable, not just by the US government, but by the Kenyans.
By the people of Kenya. I wanted to give the example, just using the same two, Global Fund and USAID and KEMSA, that at some point where USAID had issues about the operations of KEMSA and the audit of KEMSA and raising concerns about, the internal operations of KEMSA, they pushed to then have another entity.
I agree.
working with them.
Yeah.
Is because they said, despite scoring all those things that you've said, they felt, the US government, that KEMSA is not it. And so
that's the KEMSA before us.
And so they introduced, they introduced meds
yeah.
to do it.
And
private
another
entity.
institution.
What safeguards do we have that 3 years down the road of this agreement, they are not going to say, you see, this digital health agency has issues, we need another body to deal with
so we have,
digital health data, or to implement any of the aspects of this agreement.
So we have safeguards. The first safeguard is what we call the performance metrics. So we have performance metrics here every 6 months, every 1 year. So those performance metrics require what exactly did we agree we should do? Did we do it? And then there is either, and this is both ways, by the way, there is either an incentive or a punishment, in the sense that if this is what you were supposed to do and you didn't do it, what are the mitigating mechanisms? Here we've talked about some, let's say, reduction of funding. We've talked about other measures. So we have a number of safeguards within the framework, including, by the way, some of our reporting from the Auditor General. So that is going to be important because we want to build strong institutions. So what we've done, there's a whole chapter of audits and performance metrics that is tied to the entire funding. So in 3 years, it's not possible to come back to that.
Daktari, I'll say this again, release just the agreement. A lot of these questions
will be
answered incredibly easily because
we hear you, and we've already made that commitment. I think we've already made the commitment. The Cabinet Secretary pronounced himself on this, that we will make the agreement public. We will make the agreement public. By the way, there is nothing in this cooperation framework, there is nothing in the data sharing agreement that is secret. Zero, nothing.
All right.
And I have to mention this also from a historical perspective. When we were engaging with the US government, it's until the 13th of November that we took the first picture and made it public. Because even on their side, we couldn't still have communications on this. But now we can.
Okay.
I hope you understand. So, so I think within another week or maybe 2 weeks, as we do the institutionalizations, I think the public can rest easy that there is nothing in that cooperation framework that is secret. There is nothing. There is nothing that is
when you have the document in hand. As you said, nothing is changing between now and institutionalizing this agreement. So just put it out there right now for people to see. I think a week or two, it's enough time for things to die down. It's strategic timing.
But ask me the hot things. Ask me the hot things.
Okay, let's get into funding.
So, for example, let me just say that. For example, one of the hottest things I saw circulating was that this data sharing is for 25 years. That's not true. It's for 7 years.
Yes. You've made that clear. That would have been made incredibly clear had we just had a copy of the agreement. Then you wouldn't have all these rumors circulating.
Mariam, just before funding, kabla nisahau. Just again, I don't know any kwa historia contractors. They said there's none. Is there then a competitive procurement processes going to happen?
Government processes. Okay. It's government. So how does government do things? So we have laws. We have public procurement.
So a tender process.
We have laws in Kenya that governs how Kenya does contracts.
Okay. Short and sweet. Mariam, your question on funding.
Now, this is again something that is funded on the US side and on the Kenyan side as well. We're putting in money, they're putting in money. How much? What are the safeguards for the money coming from both sides? And what happens if there's a shortfall? Let's go one at a time. How much is the US putting in? You said 204 billion.
Yeah.
How much is Kenya putting in?
Kenya is putting in 850 million USD is around 100 billion.
850 billion
million USD.
Million USD.
That's what Kenya is putting in. Yeah.
Over the next 5 years. Over the next 5 years. Okay.
Which of course, is less than what we will put in because, if we consider all the investments that we have, and by the way, this is aggregate, this is total budget in terms of increment. It's on the baseline. So there's what we put now, and this is additional to what the budget is. But if you look at, and this is total, so from all our domestic resources of health financing, including county governments. So it's very achievable.
Okay. Yeah. What happens? What are the safeguards that this funding will come from both ends? That the US will put in that 204 billion, and that
the
Kenya will
safeguard
put
is
in
that the measurement, the performance measurement, is not on the money you put in; it's on how much you spend. You understand what I'm saying?
No.
So you can tell me that you will put in 200 shillings to buy a newspaper. Yeah? The safeguard there is that did you buy the newspaper? And how much did you spend?
And the receipt.
And the receipt.
It's 60 shillings.
And how many newspapers did you buy? You understand what I'm saying? So the safeguard there for both sides is not whether the US is going to put in 1.6 billion shillings. It's the end result. The end result for the financing. And I'm talking about the end result for the money.
That's not a safeguard. That's more a proof of.
So it's performance-based.
It's performance-based. It's purely performance-based. And let me say,
so if you don't meet the performance target, then it impacts the next tranche of funding.
Yeah.
Is that what you're saying?
So that's the point. So the point is that did you actually spend it? Did you spend it on that? And did whatever you spend it produce the results that we wanted here? By the way, there's a very detailed performance matrix here. So if we say, for example, that we want to achieve 97% control or suppression for persons who are on ARVs, for example. So number one, how much did you spend? Number two, did you spend it on what we said you will spend it on? Number three, did you achieve that result?
Here's the thing though.
Yeah.
We could, for example, say we have achieved 97% of like having the population of persons with HIV on antiretrovirals. We've achieved it. There we go. We had said we would put in $1 billion or $2 billion.
We have done that.
Yeah, we have done that. Fantastic. There is nothing that compels Kenya or the US to put it, if the funds are not already there. You know, you could meet all the metrics, but the next tranche of funding doesn't come. We don't put in our 250 for this quarter. They don't put in their 100B for this quarter.
Yeah.
It could
you know why we were insisting on a government-to-government agreement? Is because the Kenyan government is still here. Let me tell you something that also happened to answer your question. In March of 2025, when there was all of these anxieties about the stop work order, people had lost jobs. I went to a certain dispensary which was locked. Medicines in there was no one to prescribe them because the workers that were being supported had left, you know. There was a meeting in Serena Hotel, and that was one of the difficult meetings we've had. And you know what the Kenyan government was being asked? What are you people doing? What are you people doing now that the funding has been cut, now that people don't have medicines and all of that? The reason why we put this as G to G is because the responsibility lies on the Kenyan government to assure you of your health. So irrespective of whatever happens, whether the money is met, not met, the Kenyan government is here. And so there will not be a time again where somebody who was responsible, for example, for running a program to provide children with malaria medicines, being funded in a parallel system, then comes to say, okay, now the funding is over. What are you, government, doing? That will never happen. Now it will be government. So
governments change.
No.
It could be President Trump today in 2020.
No. But it's still Kenyan government. Whether the government changed, it will still be the Kenyan government. So the question about what is the government doing is completely gone, because it's your government now responsible for making sure that the health of the people is guaranteed.
Our partner, like we have seen, the reason why we are where we are is because our partner on the other end had a change of government and a change of strategy. So after 2028, the next presidential elections, Trump is not coming back. There'll be a new president come 2029, right? So what happens if that government of America comes and says, we don't think that Trump was actually doing the right thing. We want to review this all agreements. In fact, we are not signing any other going forward. And the ones that we had signed, we want to step back on them.
And what implications it will have.
And that is why we have said, either way, for us as a government, we are putting it in the government mechanisms. the mechanisms that we assure, based on the Constitution, Article 43, guarantees every single Kenyan the right to the highest attainable standard of health, so that it's no longer dependent on whatever any government does. Even if another government comes, they change the way, it will still be your government. Because then you can now ask the right question. And that is why for us here, what we want to achieve here is self-reliance. Self-reliance means that we build our institutions in such a way that we can hold on our own.
Who monitors the spending? You'll say government. Because NGOs are no longer in the picture. Who monitors? Where is accountability? Because there could be...
The Auditor General.
Okay.
On our end, okay. Even before
we get there,
there's on the US side.
How do NGOs monitor spending? Let me ask you that again. I don't understand that.
Independent of, you know what I mean.
What do they?
G to G, you always need oversight.
How have they ever monitored the spending? Let me ask that.
They have.
Who was oversighting NGOs?
Yeah.
No, but now who was oversighting them? In fact, right now, one of the things that we wanted, we wanted, for example, all this list of NGOs and how much money they were getting. We couldn't get that information here.
Okay.
So we had to get that information from our...
Let's go back, but we'll still come here to this. No.
The US, the Constitution guarantees us the right to, the highest attainable healthcare. That is us. It can't overreach into other people's pockets and territories, etc. So then that might mean, even through changes of government, our 850 million USD is guaranteed.
Yeah.
Out about the 204 coming from that end, which is a lot bigger. What guarantees do we have in place for that? Again, the Trump administration could be here today, could be not here in 2028, could stay, could not. We don't know.
It will not be
the beautiful...
Oh yeah, it's a second term, actually. I'd forgotten.
At least for health, and I have to give it to the American governments. I think there's been some level of friendship there, because even with the stop work order, we went through this 1 week that was difficult, but eventually through all of this, we still accessed our medicines and all of that. And so I think
that's vibes and inshallah. Like we're friends,
that's vibes, but it's important because what has happened before could happen again, And so at least there I have to say that we've been good friends, and even in difficult times, we've found ways of still. But now what is important, and I think the G2G thing, and that's why Kenyans must celebrate it, is that now you can authoritatively ask your government, that you are responsible for it. Previously, I'm responsible for it, but I'm not. I have to sort of go through some difficulties, write letters, do all. Now we are responsible for it, and there's nothing that should assure Kenyans as much as that. So you can actually now ask your government. You are responsible because and that's why we insisted on a G2G. And it's one of the mechanisms that we will use to strengthen the healthcare systems locally, to make sure that our institutions work, to make sure that they are efficient, to make sure that they're accountable, and to make sure that they deliver what citizens want.
After 2028, Missy J. Janu, on the question
of audit and accountability. So
she's trying audit and accountability by Kenyan
she's not
law.
Trying. She's made. I think her and Eric have made very valid points.
They are valid points.
Yeah, because administrations change and their interests and their priorities. What Trump did when he came in, this protectionist measure, it threw people off. But he was like, this is my priority as the US, America first, which they're still doing with this deal. It's America first. So it's a valid question to ask. What then guarantees that there'll be continuation? So I think it's a very valid concern. Yeah. So
we get the concern. We have taken safeguards in the document to make sure that our institutions will be the ones through which the services can be guaranteed. And so when something happens, it's easy to plug in. One of the difficulties, and coming again from the health workforce side, one of the difficulties we've always had, like in 2013, I was part of the union, and I'll tell you. So we used to have this HRH mechanism, and it was supported by USAID. There was workers that were being paid. When they were supposed to be transitioned to government was not prepared, did not budget. And so there was a huge long strike. Again, you've seen the issues that are going on with the Global Fund workers. So we want to make sure that there's an end to that.
Okay.
I hope you understand.
Yes,
so that Everything is institutionalized within our mechanisms, so that it is okay for me to ask you, by the way, you know, yes, I have this in my budget, but that money was coming from the Americans. Now it's not there. We just have to plug it in. But there will be no difficulty in how do I transition workers, how do I transition medicines. So the mechanisms will be country-owned, country-led, country managed.
Let's come back after the break. Again on accountability, Peter Otieno says in 2017, the U.S. suspended about $21 million in direct health sector assistance to Kenya's Ministry of Health. Concerns around corruption and lack of accountability in how funds were being handled. It's okay to ask about accountability mechanisms. We'll come back and answer that question. We do have to take a break. Again, we're still in studio with Dr. Ouma Oluga, Principal Secretary, Medical Services. We have seen some of your feedback and questions. We'll come back and raise them with him. It's coming up to 8:30.
Screens. I'll see you.
Nimekosa sherehe za 50K every week. I'm in the wrong circle, guys.
Hey, call me. People are shopping.
Yeah.
Imagine that.
He's doing well.
They could fund our health. No, joking. Jokes. Way too soon.
Yes. Before the break, we were talked about accountability. I feel like Dr. is just going to...
No.
This one, you'll just be like, what mechanisms are in place we have? Just talk to Kenyans. It's true. You know, Dr. You said something very interesting when in this conversation. You said, we are professionals, Kenya's we have some of the brightest people in the world. That has never been in doubt.
That's true.
I think somewhere along that chain, there is issues around corruption and implementation. It's anecdotal, it's documented. So I think where people are coming from in this regard is who monitors how the funding is used, who ensures that accountability is up to date, who assures that this funding is being used as it's supposed to and not being redirected, quote unquote, for things that do not serve Kenyans in the health sector. So very simply, it might be a very obvious answer, but talk to us about how you want to ensure that there'll be accountability measures for this.
Yeah, so first is the issue around the audits. So there are a number of audits embedded in the cooperation framework. One of them is what we call the performance audits. And then the fiduciary, that's the financial audits. And then there is a third. But just talking about those two, there are outcome metrics that have to be sort of achieved, and so there's a baseline. We are using 2025 as a baseline, and every 1 year we have to look at the performance of key specific things that are very useful. Okay, the third one was the process. Yeah, so there is the performance in terms of what you did, there is the money, and then there is the process in terms of how you did it. So usually, if you look at many accountability issues, they usually come from a process problem in terms of the process either was not well defined or the process was well defined, but somebody took shortcuts. So now the process metrics that are here are very clear in terms of how you get things done. So the how you get things done is what safeguards the money, the American money and the Kenyan money. And for us, again, we have embedded that within our laws. So we have the Public Finance Management, we have the Public Procurement Asset Disposal Act, we have the Constitution, so we have a way in which things get done. So if you are going to contract B, what was the process of contracting B? Did you get other, for example, quotes to know that they were the cheapest? Did you see that they could perform? Did you do due diligence to look at their history and things like that? So we think that we have
shared those, and those are the safeguards,
those are the safeguards we put.
Then there's the audit after.
Then there's the audit after,
we'll
and
get
the
to
report.
That in just a second, but we have a caller on the line, the chair of the Kenya Union of Clinical Officers, Peterson Washira. Good morning, Peterson.
Good morning, Mariam.
I hope you're well. What's your question or comment to Daktari?
Yeah, I'm very well, and let me start by congratulating my comrade and brother who we have been with in the trenches. I think that's a good deal because it means that the Kenyans that were really worried about their drugs, especially those with HIV, and my members who are clinic officers working under these programs and who are losing their jobs are not going to lose them. But I have two questions. And one is, now that there is support for the human resources for health, how is it going to be done? With the knowledge that a good number of those will be under the counties, and there's something that is being implemented under the ministry. So are they going to second this stuff to the counties, and what will that mean? Because we are having the similar problem with the Global Fund now, where they say that the Global Fund are not their staff. The ministry is saying they are working under the counties, and so the counties should absorb them. Or they were actually never transferred or seconded to the counties. So how are they going to ensure that we do not have a repeat of this? And the second question is, with the knowledge that Dr. Oluga has, having been in the union and now in the administration, and we can see we are still having a lot of human resource challenges, some that are avoidable, like what is happening with ourselves and the upcoming strike, with a CBA that was negotiated, concluded, finished, and printed, just awaiting signatures for 3 months. What is he doing to ensure that probably the knowledge he carried from the other side is brought in the administration so that these avoidable disruptions do not happen?
You just said upcoming strike. We're not aware.
We have a strike that is coming on 23rd of December.
Okay.
You have a strike celebrating coming on the 23rd of... Not... So, yeah.
So, respond to those two questions, Dr.
Yeah,
and
so Washira is my good friend.
Of health workers.
Yeah, Washira is our good friend, and I think it is bad faith for him to surprise us by announcing a strike when and he has my number. He's not called me. He has not written letters. But I think even from his tone, you could tell that he wants us to have a conversation. One of the things that we've done, and I have to give it to our Cabinet Secretary, Aden Duale, is that health workforce have been put at the forefront of implementation of UHC. We've sorted out UHC workers, we've sorted out doctors, we've sorted out even our clinical officers. I think it's important that we study what is the emerging issue. I think, Washira, you will give me the benefit of doubt that you had not informed me before. And because you're my good friend, I will not take it as bad faith, but ideally it would be bad faith. But I think the questions that he has asked are very valid. So first is that we have involved Council of Governors in these discussions. But number two, which is very important, is that the reason why these problems are there, the Global Fund, staff, all of this stuff, is because of this lack of embedding things in a government-to-government mechanism. Now, the county governments get their money through two ways. One is they get it through conditional grants, and number two, they get it through shared revenue that goes through the Commission for Revenue Allocation. There's usually this bill in Parliament that is negotiated between the Senate and the Parliament. When we have a government-to-government mechanism with money going through the National Treasury, these things will be history, because then the money can be embedded to the county government. So the fact that money was coming through, let's say, a Global Fund, and then it went, there's the mechanisms that the Global Fund uses. Only the commodities come through the National Treasury, and then the others, there are other institutions. I think we have AMREF, we have CHAI, and you will find that that is how sometimes these things are missed, and particularly because something has gone on for so long, and then people don't have foresight on it, so it's not planned. So the county says, these are not our staff, the national government, these are not our, and they're right that these are not our staff. From a contractual perspective, we have the employment laws. So Washira, you should be in the forefront saying that we've solved the problem through this G2G mechanism, because then the county budgeting process will be embedded within this government to government, because there's only one National Treasury for the county government and for the Ministry of Health, so you can't miss it. And we have already put it there that we are going to absorb 13,000. So when it is embedded within the National Treasury, then the money can be, where is it 13,000? maybe 2,000 is in this county, 1,000 is in this county, we can now distribute the money based on this. And by the way, we are very granular on that. We have even calculated how much it will cost us. It will cost us 5.8 billion per year for those staff. So we know how much it is. So I think that is going to be sorted out. But
there are questions. You know, Dr. As Peterson said, as even many of the commenters here are saying, you are saying that the issue of UHC staff has been sorted. From where you sit, it has been sorted, but it has not been sorted on the ground. And like you said, the county governments have not done their bit. So the matter of from the healthcare worker, it has not been sorted because they're still not yet fully embedded into the county payroll. Right? So even now when we say
payroll.
They're in your payroll.
Which is a government payroll.
Whose contract do they have?
The contracts were signed by the county government.
With?
Yeah, but they're in my payroll and I pay them. In fact, their salaries have doubled. I think, I mean, they're going to have a very good Christmas. From September, they have been getting salaries the same as permanent and pensionable, based on the directive of His Excellency the President. And we have gone to Parliament. Parliament has budgeted for the money. I have paid that money. The only thing I require from counties every month is to know who was at work and who was not at work, and I get it. I write letters, and I have to thank the CEO Council of Governors and all the CECs because they give us that information. Is this a permanent
way in which these things shall be run going
forward? So what needs to happen is to embed this within the payrolls of the county government,
which has not happened. Which is why I'm saying.
Yeah, but that is.
It's a technical issue.
It's a technical issue.
It's not. I'll explain why.
From a worker perspective, and I've run unions.
Yes.
And I know contracts very well. And I know employment a bit better. So
we have Dr. Kinyua we don't want to lose. He's on the line. You'll come back and continue what you're saying. Dr. Kinyua, good morning. You have a question or comment this morning?
Yes. I have a comment. So I've been listening in, and one of the bigger concerns we have as professionals is not answered. Just as a background, I'm a surgeon in this country. We are a member of a consortium of 15 countries. We have external donors. It's called COSEXA. We solicit funding to try and expand surgical education in the country. Now, one thing we have realized is that a lot of the data which we are turning over to our partners, they actually utilize it for a lot of things. Expanding the surgical education space, and all of that comes with grants, it comes with funding, it comes with a lot of financial incentives.
Right.
Now, extrapolating this to the data that we are going to export to the US, that we are going to give them access to, this is data that can be used by pharmaceuticals to develop medications, it can be used to distribute vaccines, can be used to develop medical devices. The greater good, yes, humanity benefits from this. Right. But right now, a stent for an aorta costs 2 million shillings. And data to develop those stents was actually derived from all over the world. But we are still having to pay upwards of $2,000, $20,000 to get these devices. So my question is, this data, much as we are giving it out, what will be the financial benefit to the Kenyan person? Will this data just be used by the pharmaceuticals to develop what they will without any of it trickling back to us? If it's grants, will the Kenyan benefit as much as the NGO that is bringing in that grant? So basically, that's my main issue. That
Dr. Can I ask you two questions just to clarify? First of all, you say you're in a group of surgeons that is already sharing data with third parties.
Yes.
So
under what framework are you sharing that data, Dr.?
Exactly.
And whose data are you sharing?
So COSEXA is formed from surgical societies. Okay? From these surgical societies, we developed a curriculum. So we admit students into COSEXA, train them for 5 years, and then in those 5 years, we graduate them as surgeons. Now, while they're training, they have to maintain a logbook so that I know Latif has done 500 appendectomies, so he's competent to do it.
Okay.
This information is in a logbook.
Okay.
COSEXA can now come and look at how many appendectomies are done by COSEXA residents in Kenya versus how many are done by COSEXA residents in Uganda. All of this is data, and it's very innocuously generated. Okay? So if you look at it on a broader scope, that is actually sharing data, and it is covered in the framework of training.
Actually say that Latif came for, what do you call it?
Appendectomy.
Appendectomy.
And who do you share the data with? Is it just within COSEXA?
Those are the things we want to stop, by the way.
Or is it just within COSEXA, or do you share with other people? Because you're saying, this data is used, to develop whether it's vaccines, etc.
Yeah. So this data is within a COSEXA database. You can't access it. You can't access it if you're not a surgical society. So this data is not in public premise. The worry that I see people having is that my personal information will go out there. That is not really the issue. The issue is people knowing how much of this was done, what was the outcome, what variation was used, because you can then tailor an intervention for that
but actually, you're saying that's exactly what you've been doing.
Yeah.
With your association. That's exactly what you've been doing with your association. And I'm asking, under what framework have you been doing that? Do you have licenses from the Office of the Data Protection Commissioner? Do the patients sign off?
You must have all of this.
Do the patients
must have all of this? You must have all of this license.
Does patient Latif sign off that their data will be then shared with other groups of doctors and can be used for research purposes and so on and so forth?
With other surgical societies, all of that.
That would ask the broader question. Like, let me ask you, if you ask me today, how many cholecystectomies I've done, I tell you I've done 50.
Okay.
That is my data. That is not the patient's information.
But you're still sharing that data.
So your data is you've performed 50 of these procedures, but you're saying you're not sharing anything beyond.
Did he say that is his data?
He's saying if I say I've performed 50 of procedures, that's my data, as opposed to if I'm saying I have 50 patients, 30 male, 20 female, and I performed. I think that's what you're trying to say, but there's something.
Let me just make this clear.
Yeah.
So you can tell the problem we are trying to solve. I hope. No. This is the practice that we are trying to get rid of. This practice of this is my data, we have partners, we share it. Now let me and for that, I will read a statement in our data sharing agreement. So it says the purpose of this agreement is to establish the terms and conditions under which the government of Kenya shall provide, not access, provide. Because we said you have to request, shall provide the US government any data derived from the health programs supported through this cooperation framework between the government of Kenya and the US government. This agreement aims to ensure transparency, accountability, and the effective use of resources to achieve shared objectives in health while delineating the understandings and intentions of the parties regarding the storage, the access, the protection, and the use of data. And I just wanted to go back to a small place on the provision of the data. The government of Kenya shall provide the data according to Data Protection Act, what you are asking the doctor, the Digital Health Act 2023, and other applicable laws and regulations in Kenya. And the data that will be provided is for the purpose and implementation of this cooperation framework. Now, what he was mentioning about COSEXA may not be part of this cooperation framework. But what we are also doing right now, which I think he has triggered and I have to answer this, is we have aggregated all the Kenyan data. Now, under the what we call shared resources in data, we have Human Resources for Health Registry. Under that Human Resources for HRH Registry, under that we have Practice 360, where all of this information that he has said must be there. And we are looking at what we call covered data system. So we are now scanning, and he's just triggered us that this is part of the things we wanted to stop, where somebody has, and it may not even be patient data, it may even just be the number of surgeons they have trained, but that there is still a surgeon who was trained, who has not given authorization that their data should be shared.
Because we only have about...
And I think the government of Kenya is very keen on this to make sure, not just for the US government.
We have a few more things to get through. I want to do a quick fire. Alan Maleche is on the line, and there's like 2 or 3 things that I want us to get through in about 30 seconds each. But let's listen to Alan first, get his question, and then we'll go through them really quickly. Good morning, Alan.
Morning to everyone, and just quickly to say, if Dr. Oluga needs to win our trust, he needs to make that agreement public today. That will settle everyone's nerves. But more importantly, on behalf of people living with HIV, we want to know, are there any legal restrictions to fund programs for key populations, sexual reproductive rights? Are there flexibility to use money to fund those programs? Or are we bound by the U.S. restrictions?
Right. Thank you so much. That was actually my next question, Alan. Yes. Thank you so much. Key populations.
Alan has been in this space for.
Alan is another. And thank you, Alan, for fact-checking our, you know, I have to thank him because he fact-checked some of the State of the Nation address by His Excellency the President, and he found our data very accurate. So, Alan, the work that you did, even this one you will find to be very accurate.
Yeah. Yes.
So, I think what we have looked at right now is the broader agreements in terms of support for HIV and support for TB and support for malaria. So far, we can give confidence that we have had 0 discussions about any exclusions. And from the government of Kenya perspective, we are keen to make sure that every person has access to care without discrimination. And so, Alan, we are right on the Constitution, and we will ensure from a government perspective. And again, Alan, this is government to government, so we are not restricted by anything.
Family planning?
It's the, you see, the Kenyan government, the US government is saying we'll do this together. So it's the Kenyan government to program itself. How do I want to support all the HIV services? It's not about anyone pulling any string, and I think that has to be cleared.
And the risk, though, Dr.
What's the risk?
If the US government today, as a matter of policy, says that we do not support any sexual and reproductive issues, we do not support, for example...
But there's no problem.
We don't
because
we do not support offering health support to men who are having sex with men.
Yes.
And that is one of our key programs that we run in this country. Does that mean that they could come and say, you are doing things that are against our beliefs and our policies?
And therefore we won't fund.
And therefore we'll withhold funding.
Well, so far that discussion is not on the table. And so I think it will be hypothetical for me to infer what the US government may think or do. I think, and from a diplomatic perspective, I think it would be fair that I don't start getting into that. But from a practical perspective, it's very important to know that the Kenyan government is responsible for providing you the HIV services, because the US government is now not providing. Previously, what used to happen is that there was some implementing partner that was given those resources to do it. You understand? Now, the Kenyan government is going to be responsible for that. Now, when I am responsible for that, it is upon me, and I am the principal secretary in charge of the accounting officer, means I distribute resources. I can say, okay, this is US government money, maybe it is tied to this, but then I have all these other things that may not be tied. So I can rearrange and say this.
Monies.
I have.
So it's taking the role of what NGOs did is now being managed by the government fully.
So I can say that this service that is supported by US, that Kenyan government money, maybe I'm flexible based on my constitution, based on the laws to do this, okay? And the US government money, I can as well do this package of services.
The Ministry of Health
in fact, it is more flexible right now.
Any gaps in the eventuality that they are there, right?
That's why we are doing it together. Cooperation framework.
If some things are outside the cooperation framework, the Ministry of Health is ready to step in.
Of course. And by the way, let me also say this, because I think it's one of the anxieties out there for especially the non-state actors, the non-government. This cooperation framework is simply about the resources that are coming from the State Department to us, Kenya. But there are several other resources that may be coming from the US government that is not governed by this. this cooperation framework. Yeah, and I think it's very important.
Out of time, but I know you had a question, Mariam.
There was still a question on the audit processes. We never got through. We did the safeguards, but like who is auditing then after the spending, how it was spent, was it spent on what it was intended for, and not just how it was intended to be spent. That's number one. Then there was a comment here from someone saying, Sayo says, you do not legally need the process of the AG and Parliament to disclose the agreement. Global fund agreements are available upon signature. This is a G2G, so it's different. But is there anything keeping you from just releasing this to the public? Those will be my last two questions. 30 seconds.
30 seconds, please, Dr.
There's nothing. Legally, there's nothing keeping us from releasing the agreement, and we've already made it clear that we will. I think the CS was the first one. We'll make everything public. I think that is something we will leave by. And there's nothing in the cooperation framework or nothing in the data sharing agreement that we can say is secret.
Okay. Audit after. There's what the safeguards in the agreement.
So usually the audit is done. There is the Auditor General, and then after the Auditor General, they take it to Parliament. Now Parliament then takes it to either public accounts or public investments, and those processes are important. Okay. Yeah, and just going back to that, because you mentioned those processes, KEMSA was done this. We don't want processes that are outside the country. Where somebody tells you, we can't use KEMSA because there is some other institution somewhere outside the country that has refused. And that's why it's very important. Kenyans should celebrate this cooperation and the G2G that is in
Once you make it public, we can continue to unpack, but we appreciate you taking time, 2 hours of your time to just come and try and answer some questions. Dr. Ouma Oluga, PS Medical Services, has been our guest since 7 a.m. I know there's many, many more questions to come. We might host him again. But in the next hour, Kenya Health Deal, the US-Kenya Health Deal, the data question. He's spoken to it, but we'll hear from Victor Ndede, tech and human rights expert. It's coming up to 9 a.m. He'll answer those questions in the next hour.